Hello, everyone. This is Sideris Vicaris. I am a second-year cardiology fellow at Summa Health in Akron, Ohio, and this is my submission of a clinical case for poster presentation at the annual Ohio ACC meeting coming up in October. I also had the privilege of working with Doctors Mark Ray and Umair Ahmad, who are both interventional cardiologists here at Summa Health and also helped me with my project. The title of our project is called Myocardial Bridging, a Benign Coronary Anomaly, right? Before we move on, I will say, because of the 5-slide pertinence for these cases, I do have a lot of words that I try to put onto each slide, and there is some that I had to leave out, but I will try to add that into my at least talking presentation, and it might not be on the actual slide itself. So for introduction, a myocardial bridge involves overlying myocardium of an epicardial coronary artery. This so-called tunneling of an epicardial coronary artery into the myocardium is classified as a congenital coronary anomaly. Traditionally thought to be benign, only in very rare instances are surgical interventions needed. So here, we present such a case of a myocardial bridge that's refractory to conventional treatments. Slide 3 is the case presentation. A 65-year-old male presented to the emergency department with a chief complaint of acute substernal chest pain with exertion at home. Initial troponin level was elevated, 0.381 nanograms per milliliter, and you can see the normal ranges here. Hemodynamic status was stable. His electrocardiogram showed sinus rhythm without acute ischemic changes. His chest pain resolved in the ED with 1 tablet of sublingual nitroglycerin. The patient prior to this does have a pertinent medical history of angina. So much so, about 2 years prior to this, he had non-invasive testing that led to a diagnostic left heart catheterization and coronary angiography. Coronary angiography revealed a proximal 50% stenosis of the first diagonal branch and second obtuse marginal. He underwent instantaneous wave-free ratio, or IFR, of these lesions that were both negative for hemodynamic significance. He was placed on medical therapy until his current presentation. His other history included carotid artery stenosis with carotid endarterectomy, hypertension, and hyperlipidemia. His treatment regimen included aspirin 81 milligrams, clopidogrel 75 milligrams, atorvastatin 80 milligrams, amlodipine 2.5 milligrams, and isosorbide dinitrate 5 milligrams. Because of his presentation, story, and elevated troponin, he was admitted to the cardiology service as a non-ST segment elevated myocardial infarction, a type 1 MI. Other blood chemistries, such as a CBC, BMP, and liver profile were all normal, and INR was also normal. His initial troponin level of 0.381 rose to 0.869 on recheck 4 hours later. The patient had an initial thrombolysis and myocardial infarction risk score, or TIMI, of 6 points, which indicated the need for early intervention. He underwent a left heart catheterization, left coronary angiography, and right coronary angiography. Significant findings included a mid-left anterior descending, or an LAD, segment with near complete phasic occlusion with systole that was consistent with a severe myocardial bridge. Additional findings included a first diagonal branch of 60% stenosis and a first obtuse marginal branch of 70% stenosis. No interventions were performed. His treatment included medical and risk factor modification. Metoprolol tartrate 25 milligrams twice daily was added. He was discharged to home in stable condition. However, he presented back to the ED 4 days later for recurrent angina, and he was given intravenous beta blockers, which resolved his symptoms. His ECG was unchanged from prior. His troponin chemistries mildly peaked at 0.06. His isosorbide dinitrate was stopped. The metoprolol tartrate was increased from 25 to 50 milligrams twice daily. Diltiazem extended release 120 milligrams was added. He was hemodynamically stable, angina-free, and discharged home. However, he presented again a third time now to the ED 4 days later for continued exertional chest pain. ECG again was unchanged. Troponin this time was normal, as well as his other labs. Because of his repetitive admissions, a nuclear stress myocardial perfusion study with regadenoson was performed. This revealed a small reversible perfusion defect of the mid-anterior lateral wall. Because of his recurrent angina, despite maximal therapies, with addition of myocardial injury with elevated troponins and a positive stress test, cardiothoracic surgery was consulted. After a multidisciplinary team approach with the primary cardiologist, interventional cardiologist, and cardiothoracic surgeon, the patient did undergo a 2-vessel coronary artery bypass graft, or CABG, with a left internal mammary artery, LIMA, to the mid-LAD artery, and a saphenous vein graft, SVG, from the ascending aorta to the first diagonal branch. Slide 4, discussion slide. The true prevalence of myocardial bridges is not known and has varied widely with different studies, from 5 up to 85% on necropsy series performed. Of the coronary arteries, the LAD is the most common, with reported involvement in 70 to 98% of cases. Myocardial bridges can be classified in respect to depth and length of encasement, usually 2 millimeters, less than 2 millimeters superficial, greater than or equal to 2 millimeters deep. In older patients, myocardial bridges are usually revealed by other underlying factors such as progressive coronary atherosclerosis, left ventricular hypertrophy, valvular heart disease, whereas younger patients, the first symptom can include exercise-induced angina with no known underlying cardiac history. On coronary angiography, myocardial bridges typically appear as a systolic narrowing of the vessel with a step down and a step up, demarcating the affected area, and complete or partial decompression in diastole. Adjunctive imaging with intravascular ultrasound, or IVUS, can be helpful to help define the length, thickness, and location of the myocardial bridge. Non-invasive modalities to define myocardial bridging include cardiac computed tomography, or CCT. CCT can easily visualize the coronary lumen and vessel and myocardial wall, allowing accurate definition of the myocardial bridge's features. Functional assessment tools within the cath lab are usually hampered by the complex hemodynamics. Traditional fractional flow reserve, while gold standard for fixed coronary lesions, is largely inadequate for the assessment of myocardial bridges. These dynamic stenosis lesions should therefore not be limited to resting conditions and should include chronotropic and ionotropic stimulation. Diastolic FFR with the use of the butamine challenge is more appropriate because the myocardial bridge has less influence on diastole. Additionally, IFR, which is a vasodilator-free diastolic specific index that samples intracoronary pressures during the diastolic wave-free period, can also be utilized. There are no accepted anatomic or functional classifications of myocardial bridges that provide basis for specific treatments. In general, first-line therapies accepted are beta blockers and/or non-dihydropyridine calcium channel blockers. These are attempts to reduce heart rate, cardiac contractility, and myocardial oxygen demand. Aggressive risk factor modification is also recommended. Thus far, no studies have shown normalization of a myocardial perfusion when a perfusion defect is present with a coronary stent implantation. Additionally, from case reports, these carry high risks that include coronary perforation, stent fracture, in-stent restenosis, and stent thrombosis. Currently, no data exists on refractory myocardial bridging needing surgery. It has only been noted in very rare instances that surgical approach with a supraarterial myotomy, quote-unquote unroofing an epicardial coronary artery from the myocardium, or CABG, coronary artery bypass grafting, can be considered. From the few cases that have been noted, surgical therapy appears to be safe and effective. Slide number 5, conclusion. Myocardial bridges are congenital coronary anomalies. Most are found incidentally and thought to be benign and require no intervention. However, when found in symptomatic individuals and the angina is attributed to the myocardial bridge, conservative therapies and non-invasives are sufficient to provide relief. It's only been noted in very rare instances that surgical interventions are necessary. However, when performed, they are effective at providing anginal relief. For follow-up of our case, after surgery and maintained on guideline-directed medical therapies, the patient has done very well and he's had no further episodes of angina and no further presentations to the emergency room for angina either. Thank you very much.